Your arteries have been narrowing for years, not dramatically, not in a way that produced a symptom clear enough to make you stop what you were doing and call a doctor. In the slow, accumulating way that atherosclerosis always works, depositing cholesterol-laden plaques in the arterial walls, millimeter by millimeter over decades, until the narrowing becomes significant enough to reduce blood flow to the heart muscle during moments of increased demand, and the body begins to send signals that something is wrong. Those signals are not random. They are not vague. They follow patterns that cardiovascular researchers have mapped with considerable precision, patterns that appear in the weeks and months before a major cardiac event in a proportion of adults large enough that recognizing them earlier would change outcomes dramatically. The problem is not that these signals are subtle. Some of them are remarkably specific. The problem is that they are so easily attributed to other causes, so commonly explained away by aging, fatigue, deconditioning, or stress, that they pass through clinical appointments and casual self-monitoring without triggering the evaluation that would catch the arterial disease they are reflecting. A 2022 retrospective analysis published in the Journal of the American College of Cardiology examined the clinical records of adults over 60 who experienced acute myocardial infarction and traced the preceding 12-month period for documented symptoms and clinical encounters. In 74% of cases, at least one of the 7 warning signs covered in this video had been documented in the patient's record in the 12 months before the event, either reported by the patient and attributed to another cause, or noted by a clinician and not followed up with cardiac evaluation. In 43% of cases, 3 or more of these signs had been documented. The connection was not made. The 7th sign on this list is familiar to most people in a general sense, but is misunderstood in a specific way that causes most adults experiencing it to underestimate its significance. The 4th sign is the one referenced in the title, because it is simultaneously the most specific indicator of arterial blockage available from physical observation, and the one that most adults and many general practitioners have never been told to look for, or what it means when they find it. Before we begin, tell us in the comments right now, how old are you and where are you watching from? And have you experienced any chest discomfort, unusual fatigue, or other symptoms that you have been attributing to aging or stress? Drop it below. We read and respond to every single comment. Warning sign number 7. Shortness of breath with activities that never used to cause it. This is the warning sign whose general outlines most people are familiar with, but whose specific pattern they consistently misinterpret in ways that prevent it from triggering appropriate cardiac evaluation. Cardiac-related shortness of breath is not the breathlessness that comes from being out of shape. It is a change from an individual's own baseline. An adult who has been walking up the same flight of stairs every day for 5 years, and who suddenly finds that the same stairs require a pause at the top, or who finds that a walk that was previously effortless now produces a level of breathlessness that requires a few minutes to recover from, is experiencing a change in their cardiopulmonary reserve that has a cause worth investigating. When coronary arteries are significantly narrowed, the blood supply available to the heart muscle during physical exertion is reduced relative to the heart's demand for oxygen during that exertion. The heart muscle that is not receiving adequate blood flow during increased demand begins to function less efficiently. Cardiac output falls below what the exertion requires. The lungs respond to the reduced forward flow by increasing respiratory rate and effort to maximize oxygen extraction from each breath. The person experiences this as shortness of breath during the activity that triggered the inadequate coronary blood supply. The key clinical feature that distinguishes cardiac breathlessness from deconditioned breathlessness is its reproducibility and its progression. Cardiac breathlessness occurs consistently at a specific level of exertion and worsens as the arterial narrowing progresses. Deconditioned breathlessness improves as the person exercises more regularly over weeks. An adult who notices that their breathlessness on a specific activity has been getting gradually worse over 3 to 6 months rather than better, despite maintaining or increasing their activity level, as a pattern that warrants cardiac evaluation rather than a fitness program. A study published in Circulation found that in adults over 60 who were eventually diagnosed with significant coronary artery disease, exertional breathlessness was the presenting symptom in 47% of cases, compared to 32% who presented with chest pain. Breathlessness was a more common first symptom of significant coronary disease than chest pain in this population, yet it was evaluated with cardiac testing far less frequently than chest pain in primary care settings. Warning sign number 6: jaw pain, neck pain, or left arm discomfort during physical activity. These are the referred pain patterns of cardiac ischemia that everyone has been told about, but that most people fail to recognize when they experience them because they occur without chest pain, because they are intermittent, and because the jaw, neck, and left arm each have their own obvious non-cardiac explanations that come to mind first. Referred cardiac pain occurs because the heart and the jaw, neck, and left arm share sensory nerve pathways that converge in the spinal cord. When the heart muscle is experiencing ischemia from reduced coronary blood flow, the pain signals travel up the cardiac sensory nerves and enter the spinal cord alongside the sensory nerves from these other structures. The brain, which processes the signal, sometimes cannot distinguish between pain originating in the heart and pain originating in the jaw or arm, because the signals arrive through shared pathways. The pattern that distinguishes referred cardiac pain from musculoskeletal pain in these locations is its relationship to exertion. A jaw ache that appears consistently during a brisk walk and resolves reliably within minutes of stopping is behaving like cardiac referred pain. A jaw ache that is present at rest, that is related to dental issues, or that does not reliably change with exertion, is less likely to be cardiac in origin. Similarly, left arm heaviness or aching that consistently appears during physical activity and consistently resolves with rest is the classic anginal equivalent pattern that warrants cardiac evaluation regardless of whether any chest discomfort accompanies it. The clinical evidence for this sign's significance is straightforward. A retrospective study in the European Heart Journal found that adults who reported exertion-related jaw or neck discomfort without chest pain had coronary artery disease on angiography in 62% of cases when the symptom was consistent with the exertional pattern described above. More than 6 out of 10 adults with this specific symptom pattern had significant coronary disease when they were evaluated. Before we continue, if this has been useful so far, hit that like button so more people can find this information. Subscribe and turn on notifications. New content every week. Warning sign number 5. Ankle swelling that appears in the evening and is gone by morning. Ankle swelling that appears and disappears in this specific pattern is the classic presentation of early cardiac decompensation, specifically of the reduced forward output from the left ventricle that produces backward pressure in the pulmonary and systemic venous circulation. When the heart is not pumping forward efficiently enough to keep pace with venous return, venous pressure rises in the systemic circulation. The elevated venous pressure forces fluid out of the capillaries and into the surrounding tissue, where it accumulates due to gravity in the lowest available space, which is the ankles and lower legs in a person who is upright during the day. During sleep, when the body is horizontal, gravity no longer concentrates the fluid in the ankles. The fluid redistributes and is partially reabsorbed into the venous circulation and processed by the kidneys overnight. By morning, the ankle swelling is gone. By evening, after another day of upright position with the compromised forward output of the heart unable to fully clear the venous congestion, the swelling reappears. This morning clear, evening swollen pattern is clinically specific enough that cardiologists use it as a diagnostic indicator for early heart failure even before echocardiographic evidence becomes definitive. Adults who notice this pattern developing for the first time or who notice it worsening over weeks or months have grounds for a cardiac evaluation that includes an echocardiogram rather than simple reassurance that ankle swelling is common in older adults. The distinction from purely venous causes of ankle swelling involves the pattern's bilateral symmetry and its relationship to the time of day, rather than to specific activities. Pure venous insufficiency produces ankle swelling that may be persistent rather than resolving overnight, that may be associated with visible varicose veins, and that typically develops after prolonged standing rather than following the strict morning clear, evening swollen cycle of cardiac decompensation. Warning sign number 4, a diagonal crease in the earlobe. This is the sign that the title references, the one that is simultaneously the most specific physical indicator of coronary artery disease available from simple observation, and the one that most adults have never been told to look for, that most general practitioners do not routinely examine for, and that has a research foundation substantial enough to warrant inclusion in any serious discussion of early coronary artery disease detection. The Frank sign, named after Sanders Frank, who first described it in 1973, is a diagonal crease that runs from the tragus of the ear, the small cartilaginous projection in front of the ear canal, diagonally backward across the earlobe at approximately a 45-degree angle. The crease must be diagonal, rather than simply a fold from ear position during sleep, which creates a horizontal crease rather than a diagonal one. And it is most significant when it is bilateral, present on both earlobes rather than just one. The mechanism connecting the Frank sign to coronary artery disease involves the microvascular supply of the earlobe. The earlobe is supplied by a terminal branch of the superficial temporal artery that does not have significant collateral circulation. When atherosclerosis affects small and medium vessels, the earlobe microvasculature is among the first to show the structural changes of reduced blood supply, manifesting as the tissue reorganization and collagen redistribution that produces the visible diagonal crease over time. The research on the Frank sign and coronary artery disease spans 5 decades and includes multiple large studies. A meta-analysis published in the American Journal of Medicine reviewed 42 studies examining the Frank sign and coronary artery disease, pooling data from over 11,000 patients. The presence of a bilateral diagonal earlobe crease was associated with a 2.2-fold increase in the likelihood of significant coronary artery disease on angiography, independent of age, sex, blood pressure, and cholesterol levels. The sensitivity was 62% and the specificity was 68%, making it a moderately strong indicator that warrants further cardiac evaluation when present, rather than a definitive diagnostic finding. Subsequent research has refined the understanding of the Frank sign's significance in the context of other risk factors. Adults over 60 with a bilateral diagonal earlobe crease alongside any 2 other cardiovascular risk factors, including hypertension, dyslipidemia, diabetes, smoking history, or family history of premature coronary disease, have a post-test probability of significant coronary artery disease that justifies coronary calcium scoring or stress testing as a next diagnostic step, even in the absence of any cardiac symptoms. Check your earlobes in a mirror. A diagonal crease running from the front of the earlobe backward at approximately 45 degrees, present on both sides, that you have not specifically noticed before, is something worth mentioning to your physician at your next appointment, alongside a request for cardiovascular risk assessment. Warning sign number 3, fatigue that is disproportionate to the level of activity performed. Cardiac fatigue is qualitatively different from ordinary tiredness, and understanding the difference is important for deciding which experiences of fatigue warrant cardiac evaluation and which warrant a good night's sleep. When the heart is not delivering adequate cardiac output for the demands being placed on it, the muscles and organs receiving that reduced blood flow begin to operate at reduced efficiency. The skeletal muscles fatigue more quickly because they are receiving less oxygen per unit of work than they require. The brain receives less oxygen than it needs for optimal cognitive function, producing the mental heaviness and slowed thinking that accompanies cardiac fatigue. And the kidneys, receiving less blood flow than their filtration demands require, accumulate metabolic waste at a slightly higher rate than optimal, contributing to the systemic metabolic burden that the brain experiences as exhaustion. This cardiac fatigue is disproportionate to the activity that triggers it. A person with significant coronary artery disease may feel profoundly tired after walking 2 blocks, not because 2 blocks of walking is inherently exhausting for an adult in their 60s, but because their coronary blood supply cannot meet the cardiac demand of even modest exertion without producing the reduced output that cascades into systemic fatigue. The diagnostic pattern that points toward cardiac fatigue rather than other causes is its relationship to activity and its progression. An adult who has been managing a specific level of daily activity without undue fatigue for years, who notices over 3 to 6 months that the same activities are producing increasing fatigue, and who finds that rest does not fully restore their energy to baseline, is experiencing a pattern that is more consistent with progressive cardiac limitation than with normal aging or sleep quality issues. Warning sign number 2. Palpitations or irregular heartbeat occurring during or after exercise. Palpitations at rest are common and frequently benign. Palpitations that occur specifically during or immediately after physical exertion in adults over 60 with any cardiovascular risk factors deserve a more careful evaluation than those occurring at rest, because their timing points toward an ischemia-triggered mechanism rather than the benign vagal or electrolyte-related mechanisms that produce most resting palpitations. During physical exercise, the increased oxygen demand of working muscles requires increased cardiac output. The heart achieves this by beating faster and with greater force. In a heart with significant coronary artery disease, the increased demand during exercise may exceed the capacity of narrowed coronary arteries to deliver adequate blood flow to regions of the heart muscle. Ischemic cardiac muscle is electrically unstable. It produces abnormal electrical signals that manifest as arrhythmias, often experienced as palpitations, skipped beats, racing, or irregular rhythm, that occur during the exercise that triggered the ischemia or in the minutes immediately following it. Exercise-induced palpitations that are new, that are worsening, or that are accompanied by any of the other warning signs on this list represent an indication for a stress test rather than reassurance. The exercise setting that produces them is providing diagnostic information that a resting ECG in an office cannot replicate. Warning sign number 1, chest tightness, pressure, or heaviness during physical activity that resolves with rest. This is the classic angina pattern, and it remains the number 1 warning sign of significant coronary artery disease because of the directness of its mechanism and the consistency with which it predicts significant narrowing of the coronary arteries. Angina is not the same as a heart attack, and understanding this distinction is critical for appropriate response. Angina is the symptom produced when a narrowed coronary artery cannot supply adequate blood flow to the heart muscle during increased demand from exercise, producing ischemia that generates the discomfort and resolves when the demand decreases with rest and the marginal blood supply becomes adequate again. A heart attack occurs when a coronary artery becomes completely blocked, typically from plaque rupture and acute clot formation, producing prolonged ischemia that damages cardiac muscle rather than simply stressing it reversibly. Stable angina, which follows the predictable exertion-onset rest relief pattern, indicates significant coronary artery disease but not an immediately life-threatening situation. It is a signal that should be evaluated without dramatic delay, that should prompt a referral for cardiac testing, and that should result in a treatment plan that addresses both the symptom management and the underlying coronary disease. What transforms stable angina into an urgent situation is change in pattern. Angina that occurs at lower levels of exertion than it previously did. Angina that takes longer to resolve with rest. Angina that occurs at rest when it previously only occurred with activity. or angina accompanied by shortness of breath, sweating, nausea, or radiating pain into the jaw, neck, or left arm, represents unstable angina or possible acute coronary syndrome that warrants immediate emergency evaluation. A 65-year-old retired construction worker came in describing a sensation he called tightness in the chest that appeared when he walked uphill, and that resolved within 2 minutes of stopping. He had been having this sensation for approximately 3 months and had attributed it to a muscle strain from moving boxes. He had no prior cardiac history. He had mild hypertension that was medically managed. When he looked in the mirror that morning before the appointment, he had noticed for the first time, prompted by reading about it the night before, that both his earlobes had a diagonal crease he had never previously registered. His stress test that afternoon showed significant inducible ischemia in the anterior wall distribution. His coronary angiogram the following week demonstrated a 78% stenosis of the left anterior descending artery. 2 of the 7 warning signs on this list were present simultaneously. One of them was a symptom he had been managing for 3 months. The other was visible on his earlobes every morning when he shaved. 7 warning signs, each of them specific enough to point toward coronary artery disease when present in the right pattern. Each of them easily and understandably attributed to other causes in the absence of specific knowledge about what they mean, and each of them present in the weeks and months before major cardiac events in a proportion of adults large enough that recognizing them earlier would change the outcomes that follow. Check your earlobes. Notice your breathlessness patterns. Track whether your energy on a given level of activity is the same as it was 6 months ago or whether it has changed. Bring the answers to a physician who knows to ask about the pattern and not just the current complaint. Now we want to hear from you. Have you noticed any of these 7 warning signs? And did the earlobe sign surprise you? Share in the comments below. We respond to every single one. Subscribe if you haven't already. Next week, we are covering the 5 blood tests your doctor almost never orders, and that are the only ones capable of detecting what is happening in your arteries before a standard panel shows any abnormality.